started as a gastroenterologist back in 2001 at the Amsterdam University Medical Center, starting to build a esophageal research group that had an interest in endoscopic detection and endoscopic treatment of early neoplasia, meaning that most of the cases and most of our research was actually focusing on Barrett's esophagus. How common Barrett's esophagus is in the general population is a little bit of a guess, but it's a disease that is related to reflux, and we know that if we do endoscopies in patients for that indication, we will find the Barrett's esophagus in approximately 10 to 12% of those patients with long-standing reflux. And Barrett's esophagus is relevant because it's the most important predictor for esophageal adenocarcinoma. And that's a disease when diagnosed at a symptomatic stage. So if we wait until the patient develops symptoms, really has a very, very poor prognosis. Whereas if we keep these patients with a Barrett's esophagus under endoscopic surveillance, we have the opportunity to detect that disease in an asymptomatic stage when the prognosis is excellent. And you can actually treat these patients endoscopically in an outpatient setting. Well, we don't have many, actually. We have the length of the Barrett's esophagus as something that you determine during the endoscopy. And then we have the pathology of the histological samples that have been obtained from biopsies that are taken during an endoscopy in the absence of visible abnormalities. So the majority of Barrett's patients will have no abnormalities upon endoscopy. We'll then have random biopsies taken by the endoscopist, and then determined by the length of the Barrett's and the results of that pathology, the surveillance interval is then determined, which then ranges for non-dysplastic Barrett's somewhere between 3 and 5 years, depending on the length of the Barrett's. And for patients that have early neoplastic changes, low-grade dysplasia, that's a little bit of a dilemma, but then either surveillance is intensified to 6 months and then annually, or we decide to treat these patients prophylactically. The guidelines say that ablation is actually only indicated for patients who have a significant risk of progressing to high-grade dysplasia or cancer, or who already harbor high-grade dysplasia or have an early cancer removed. But the biggest dilemma is for those patients with low-grade dysplasia, which is a significant part of the surveillance population. If that population in itself is immediately amendable for that endoscopic ablation, or that we should do something to better risk stratify these patients. And guidelines actually say that you need to have such a diagnosis of low-grade dysplasia, which occurs in about 10% of all Barrett surveillance patients during some time point of their endoscopic surveillance, to have that diagnosis histologically reviewed by an expert pathologist. Yeah, that's a good question. Actually, that's very poorly defined, and we've tried to come up with some kind of definition saying that should then be a pathologist who is recognized by their peers as having significant additional expertise in the field of Barrett's neoplasia, has a caseload and a cumulative caseload over the years in assessing these cases. Generally is a pathologist that has participated in training other pathologists and has a scientific track record in that field. So that really narrows it down to just a handful of pathologists in my country, but basically countries of the size of Germany and France and the UK, and even the US. You will not come up with a list of more than 5 to 10 experts that will be picked by other pathologists in the field. And it's very dependent in how well known a community-based gastroenterologist is in the field of pathology to actually pick that expert pathologist, and how do we then get access to that expert pathologist. In my country, which is small and everybody knows each other, that's easy. In the US, that generally means that, although required, many community-based gastroenterologists do not send out cases with low-grade dysplasia to a well-known expert pathologist in the States. So simply that required pathology review is simply not flying here in the States. So that means that if that community-based diagnosis of low-grade dysplasia is not further purified, that means that we're stuck with a group of patients that is labeled as being high risk, but in fact does not have that high risk, because if those biopsies would have been reviewed by an expert pathologist, we know that 70% of those patients are actually downstaged to non-dysplastic Barrett's. And those downstaged cases do not have an increased risk for progression and therefore should logically not be ablated. So if you're not sending out these cases of low grade for a second pathology review, you will be overtreating 70% of your patients with an invasive ablation technique that, although effective, is not without complications. And it also leads to an underestimation of the patients that truly have low-grade dysplasia. If you don't decrease the disease reservoir by purifying it, you actually don't get a perspective that those 20% that really have low-grade dysplasia after second pathology review, that those patients really have a dramatic risk of progressing to high-grade dysplasia or cancer. So within 5 years, those patients have somewhere between 30 and 40% chance of progressing to high-grade dysplasia or cancer. And if you're not labeling them as a risk patient and you'll be sending them off for 5 years, which is an acceptable surveillance interval for a non-dysplastic case, those patients might actually return with a lesion that's outside the window of opportunity for endoscopic treatment, and then may either need surgery or even die from their disease if they're not adequately labeled as being at high risk for neoplastic progression. So the rationale for that study actually is based on some of the things I said previously, that low-grade dysplasia is something that is quite frequently diagnosed in community practice. And if we don't purify that diagnosis into a low-risk group, which is the majority of those cases, and a high-risk group, then we either are over-treating patients with ablation, or we are reassuring patients that they are not at risk, where in fact they are at risk. And given the limitations of pathology review, especially here in the States, with expert pathology being poorly defined and not widely accessible, and also anticipating that even an expert pathologist is not the perfect gold standard, and that we probably will be looking at a wide variation in those pathology assessments by those experts, we wanted to know if TissueCypher, which we tested in 5 previously independent studies, and was actually found to be a very good test on non-dysplastic Barrett's biopsy. So basically a biopsy that any pathologist would call normal. And yet TissueCypher was able to identify those cases that were going to progress within 5 years in a way that no other pathologist actually would be able to do. So it made just common sense to see if we have such a tool available, and if risk stratification of low-grade dysplasia is such a problem, how would TissueCypher then perform on those cases? And how would it perform relative to the performance of a panel of pathologists that will be looking at the same slides? So the panel of pathologists that we asked for this study was pretty unique. We just didn't grab 30 pathologists, but we selected them from 5 different countries: the Netherlands, Germany, Belgium, UK, and the US. And then we split them up 50-50. So 15 were really the experts with the, although arbitrary definition, as I previously told. So these were the pathology hotshots within each country for Barrett's histological assessment. So we had 15 of those. And they were matched one-on-one with a community-based pathologist in their own country who had no specific Barrett's expertise yet who will be assessing the biopsies coming through their community practice. But these would then be the pathologists that will do the initial assessment. But in case of low-grade dysplasia, they will be sending out the biopsies to an expert pathologist, such as in the panel. So those 30 pathologists then looked at a cohort of biopsies obtained from 154 patients, all with a community-based diagnosis of low-grade. And we had the same material assessed by TissueCypher. And the first thing we found was that pathologists did what they were supposed to do according to the guidelines. We saw the same thing. We're downstaging a significant number of patients by the pathologist. About 70% gets downstaged to non-dysplastic Barrett's. And they have a low risk of progression. There's a small group of about 20% that get confirmed to have low grade, and they have a high rate of progression. But then if we looked at how good these pathologists were in agreeing on this, they were all over the place. So if we looked at how many of these progressors they identified, in the cohort of 154 patients, there were 24 progressors. And logically, not all pathologists identified all progressors at high risk, but the range for sensitivity and specificity were all over the place. And TissueCypher, logically, is an objective and easy accessible tool. They were avoiding cases that were then overdiagnosed and would then have been unnecessarily ablated, but more importantly, a significant group of patients that would have been underdiagnosed will be downstaged by the pathologists as being non-dysplastic, whereas they did progress within 5 years. And those cases might actually have come back with a disease stage that might have compromised their prognosis to be cured of esophageal adenocarcinoma. But in all fairness, pathology as a tool for risk stratification of community-based low-grade dysplasia is simply an inadequate tool. The best performing pathologists, yes, they do their job, and they fit the reasoning why the guidelines say that you need to have that second pathology review. But the person who is in charge of sending out these biopsies, he or she doesn't know what the performance of the pathologist they will be sending the biopsies to will be. And our study shows that it's all over the place. So the political correct answer is probably to say you need to do both. So you do expert pathology and you do TissueCypher. And then TissueCypher will be an adjunct on top of that expert pathology review, accepting all the downsides of the performance, as I just said. To me, that just doesn't make sense. Then you're taking your best set, your best performing set, which is TissueCypher, and you're using it as an adjunct for something that's inadequate. So if you have two tools, you should pick your first tool as the best first step of your diagnosis. And it's time that we turn things around. We need to look if, after TissueCypher, if there's any adjunctive value of sending biopsies out for expert pathology review. And we're currently doing the modeling on this because it depends also on what the consequences are, what type of progressors are the pathologists missing, and what type of progressors is TissueCypher missing. And what are your chances to pick a good pathologist versus your chances to pick one who's either overdiagnosing or underdiagnosing. So there may be a more scientific answer to your question in the near future. But for the time being, I would say that it's time that we integrate TissueCypher as the first step for risk stratification of community-based low-grade dysplasia. And then we can still see if there's any place for an expert pathologist on top of that. My guess is that actually that will have no further place and that we will stick to a more objective, AI-based, easy accessible, and reproducible tool to make those calls for our patients. Indefinite is a kind of escape diagnosis for pathologists. Basically says, I'm not really able to make a distinction between reactive and inflammatory changes, atypia, versus early neoplastic changes, dysplasia. And in all fairness, that can really be very difficult. especially if the patient has poorly controlled reflux disease, etc. The frequency in which pathologists make that diagnosis of indefinite is, at least for my country, it's basically a quality parameter for pathologists. If he's making the diagnosis of indefinite in 80% of the cases, he's basically not making any diagnosis. But on average, you can anticipate that you will have the same frequency of indefinite diagnosis as you will have for low grade. And a good pathologist will have 5% or 5% versus 5% at any time during the course of a patient surveillance history. So it's a big piece of the pie, actually. And guidelines are not very explicit on this. But in general, the advice is to treat these patients alike patients with low-grade dysplasia. The guidelines focus on low-grade dysplasia, but in my country, we were sending out all indefinite and low-grade dysplasia for pathology review. And in our study, for instance, we grouped indefinite with low-grade dysplasia. If we were not doing that, the sensitivity of pathologists dropped dramatically. So there is a higher rate of progression in indefinite. It's somewhere in between the low-grade and the non-dysplastics. And the daily practice is to treat them the same way as low-grade. So if you're not sending out low-grades, you will not be sending out indefinite. If you're ablating low-grades, there's a significant chance that you might also be ablating indefinite. And so the problem that we discussed earlier during this talk is actually, it's only the tip of the iceberg, because if you add the indefinites to that, it's at least double the magnitude. And then the non-dysplastics. Here there are pathologists, you can't blame the pathologists here. And here there's not a lot of variability between pathologists. The kappa scores for the diagnosis of non-dysplastic Barrett's, as well as on the other side, on the extreme of cancer and high grade, if you group those two together, they're excellent. The pathologist is making the right diagnosis, but he's simply stuck. He's not able to see differences in the morphology of a patient that is normal versus another patient that is normal, but who will progress in 3 or 4 or 5 years' time to early neoplasia or more advanced cancer. That requires something that is probably too complex for the human eye or the human brain. But we know from TissueCypher, actually the first studies that we did were on looking at non-dysplastic biopsies of a group of patients that we knew had progressed versus a group of patients with non-dysplastic biopsies that we knew had not progressed. Under the microscope, they look identical. Yet TissueCypher picks up somewhere between 50 and 60% of those, while there's no morphological changes, which is amazing. So, if we agree that a high risk or an intermediate risk score for a patient that has been offered as a community-based low grade, then qualifies the patient for either intensified surveillance or ablation, doesn't it make sense that the same risk score for a non-dysplastic biopsy should have the same therapeutic consequences? And if that's the case, then and the earlier studies with TissueCypher on the non-dysplastic biopsies actually suggest that you could eliminate maybe the majority of patients that are going to progress. And that would reduce the disease reservoir. So the same number of Barrett's patients, you just kick out the ones with high risk, you're left with a group that has such a low risk that it may just not be efficient, ethically justified, or whatever name you give to that, to keep these patients under surveillance. And there's in the future, it's likely that we will add additional biomarkers, not on the protein level, but maybe on the genomic level, or methylation level, that actually can boost that sensitivity. So my take for this for the future is that pathologists will have to do something different than looking at morphology of Barrett's, because the future is in the molecular biology of the disease that the human brain cannot assess. But AI-assisted tools like TissueCypher, maybe with 1 or 2 add-ons, will really determine how we're going to manage our Barrett's patients in the future.